Welcome back to Clot Conversations, the show where we dive deep into the world of thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm thrilled to be joined once again by our co-hosts, Dr. Maha Othman from Queen's University and Dr. Jamil Abdulrahman from Toronto General Hospital. Get ready for another fascinating episode covering the latest research in thrombosis. Thanks for tuning in.
In this episode, we will be discussing a recent publication from the journal Cancer Epidemiology, The Incidence of Venous Thromboembolism by Type of Solid Cancer Worldwide, a systematic review. We're pleased to have one of the authors join us today, Jordan Harry.
Jordan Harry holds a Bachelor in Life Sciences specialization in cardiorespiratory sciences and a master's in translation medicine with a focus on cancer research, both from Queen's University. She is also currently pursuing another degree, which is a Bachelor of Sciences in Nursing at St. Lawrence College in Kingston, Ontario. Thank you for participating on our podcast, Jordan. Let's get started. So I guess in the beginning, we all know that there are considerable literature on VTE and cancer. So I'm curious in the beginning to ask you, what motivated you to conduct this systematic review?
Yeah, so our group had been looking at cancer-associated thrombosis for a significant amount of time. And every time we went into the literature, we were finding that there was a lot of different papers, but often there was different answers. So there was different incidence rates, or there was an overarching blanket statement that was saying, these are the types of cancer with the highest incidence rates. But there was no source that actually consolidated all of this together. And if you were just to pull one individual paper, you might have seen a significantly different result than if you looked at a different paper. Our concern is this could cause a lot of variability and really bias a clinician or researcher's response and hinder their ability to really make definitive, meaningful conclusions. So this made it clear to us that there was a significant need to have a comprehensive global overview where we had a data set that consolidated all of the incidence of VTE by type of solid cancer in one place so there could be a resource people could turn to.
Yeah, this makes absolute sense. And I'm glad you conducted this review, and we look forward to hear more about it in this podcast.
So with your systematic review, can you tell us which type of studies you included and with which participants?
So when we looked at the different studies, we were very open to multiple different models as long as the incidence of VTE was reported. So when we were looking at inclusion-exclusion criteria, we particularly focused on adults with solid cancer, as my background is in solid cancer research, as well as our group was looking at different solid cancers at the time. We very much focused on any studies that were published after January 2000, as the Wells score for DVT and PE were actually established in 1998, and there was also advancements in terms of CT imaging modalities at the time. So we were concerned that anything that was older wouldn't necessarily be relevant to the current incidence rates. In terms of exclusion, we really were careful when we looked at these studies to ensure that there was no individuals that were included that could have a bias towards increased or decreased clotting. So we excluded those who had a history of thrombotic diagnoses or those that were on prophylactic anticoagulant use. As our focus was on VTE, we did exclude any that had mentions of arterial thrombosis. If there was a paper that had both arterial thrombosis and VTE, we would just take the VTE data. The one thing that we came across when we first started that was quite interesting was looking at novel therapeutic interventions. So a cursory search of the literature, we saw that there was a lot of studies, especially within chemotherapies, that had novel chemotherapies that either didn't make it to market or just did not have data yet that we could really see what they did in terms of incidence of VTE. We made the decision that those would not be generalizable to the population. So therefore, how we handled those studies was that we would only use the control group and we would not use that novel therapeutic intervention group. We were actually quite lucky. So as our question was quite straightforward and we knew exactly what we were looking for, as we went through our process of actually choosing the studies, we ran into relatively few roadblocks, which was excellent along the way.
And that's prospective studies, retrospective studies, both? Or
So we had randomized control trials, we had retrospective cohort studies, and prospective cohort studies. We did exclude any individual case reports or case series, as those would not be generalizable to the population. And we also excluded review articles, as we didn't want articles to kind of be mentioned multiple times and therefore potentially bias the incidence rates.
Okay, great. So now on to the findings. What were the main findings of the study from those selected articles?
So we had a lot of different findings for this study. Anyone who knows me as a researcher knows that I like to dive into multiple different things to try and get the best overall picture that we can. So overall, we found that the incidence of VTE across all types of solid cancer was 9.74%. Every time I discuss this, I always put it in context because the number alone doesn't really land the way that it should. This is meaning that approximately 10 in every 100 individuals with solid cancer, independent of the type of cancer, might experience a VTE, which is actually an astoundingly high number. When we looked at that further, we wanted to see if it was different across the individual types of cancer. And first and foremost, it definitely was. So what we saw was those with the highest incidence were gastroesophageal, ovarian, and brain cancer, whereas those with the lowest incidence rates were prostate and vulvar. And if you look at the figure within our article, you can see that they were actually quite different in terms of these incidence rates. We wanted to take it a step further and look at sex-specific differences. Originally, we took that overall view again, where we took all the mention of male versus female sex data. And when we looked at this, we actually saw that there wasn't really any difference between the groups. Notably, within these, what we did was we also included biological sex-specific cancers, such as ovarian cancer or testicular cancer, within their respective categories. So we wanted to take it a step farther and assess if we looked at cancers that affects both biological sexes, and we wanted to see if there was differences within those groups. And we actually found that there were. And this is one of the areas of the study where I would really love to see future data on, because the more I look at it, the more that I see that there's room to grow. So when we look at this, we saw that those with the highest incidence rates in females were urological, biliary, and lung cancer, whereas those within males were pancreatic, brain, and lung. And this was really interesting to me because if you look at the overarching statements within the literature, the male incidence rates actually closely mimic what we are seeing. So potentially females are not represented in those general statements or that data to the extent that we would have considered. Also, beyond ranking, you could actually look at just individual cancers and see within individual types of cancer that the outcomes were actually quite different between males and females. A couple of those that were relevant were gastric cancer and thyroid cancer. So we wanted to wrap it up with our big, lofty goal of the global incidence of VTE, where we were actually trying to map this out worldwide. First and foremost, I'd just like to say that there was large portions when you look at our overarching map where they were not represented, and we did not have data from a lot of different regions. Although we did our best with the model of a systematic review to get as much as possible, unfortunately, if there are not publications available, that data is not going to be included in the data set. So I think that we have a lot of room that we could do to improve that for global representation. But we did see that countries such as Spain, Mexico, and Ireland had the highest incidence, whereas the lowest incidence was actually within Singapore. And notably, it was 2.36%. So if you remember back to our overall incidence, which was 9.74%, 2.36% is a lot lower. So potentially it shows us that there's things that we can look into that might attribute to these differences.
Very interesting stuff. Can you tell us about what type of challenges you faced with the data extraction?
Yeah, so for data extraction, right off the bat, we had developed a template and we consulted with the team to make sure that everyone's different expertise for VTE were going to be included. So we tried to pull absolutely everything that we could that could be relevant or influence incidence rates. So regarding study characteristics, those are relatively straightforward, where you pull your title, you pull your authors. Notably, we had a slight issue with just a couple papers in terms of country, because there were some international studies that were included that would provide one overall incidence rate for the different types of cancer they discussed, but they didn't necessarily break it down by country within those studies. So we had a little bit of difficulty on how to sort those on the global scale. And for those where we were not able to eventually get that data, what we did was we included an international category. So if someone was interested in those additional studies, they could look towards them a little bit more. For our extraction of the incidence data, it was actually very straightforward because our inclusion-exclusion criteria was there. If there was no incidence data, they were not actually included within the study, nor if we could not calculate the incidence. What we did find here was there was difficulty sometimes getting male versus female incidence data. So I mentioned our outcomes for that incidence data, but notably only 66 out of the 124 studies actually reported male versus female data. This was actually quite discouraging to me because we could see that the outcomes were actually different between these groups. And therefore, it was really important that we look at it going forward. You might get a general blanket statement for a paper that says 21.7% of the population was female, but it doesn't pursue that further to actually say what individuals experienced those VTE events. So that's one area that was a little bit troubling to us, but we did our best with what we had. Where we ran into the most of our difficulties was areas such as patient demographics, therapeutics, the time point of VTE, and comorbidities. We tried to pull all of this data to the best of our ability, but the difficulty was that we couldn't always trace back those comorbidities to specific patients. We didn't know exactly which patients had VTE and what exactly their time point, demographic, or therapeutics were. So we paid a lot of attention to this, and I actually really thank my team for their dedication because each person kind of took on one of these individually difficult aspects and dove into it as much as they could. So you will see we have some narration in the study, but unfortunately, we were not able to make extravagant overall conclusions for these factors.
So I guess this is a good segue to talk about the gaps in reporting data with respect to cancer-associated thrombosis. So I want to ask you, based on the systematic review that you've done and your experience with this work, what is it that we do or help to guide researchers to do better so that we can compile data in a meaningful way?
So based on the difficulties that we had in data extraction and some of the lingering questions that exist on both my mind and generally on my team's mind, we wanted to say that we really need to do a little bit better considering our data. And the way that I would say is from a research perspective is that we really have to think not only about the question that we are asking and trying to solve, but thinking about how our data is important and can be used for other research projects that exist. So in particular, I think we need to do better on patient demographics, because when we were assessing our global data set, we're assuming a fairly homogeneous population within different countries. But we know that that's not the case, and there are a lot of variabilities within countries. So we shouldn't just be looking at a per country perspective, but also looking at who's involved in those studies within the countries. But unfortunately, if that data is not available, we can't take that additional step. For time point, it's actually quite difficult with VTE because a lot of different studies will only look at specific time points, which causes a lot of things within the literature where we're not sure 100% what the most appropriate time point is to look for VTE. So that being said, I think that it's really important to be clear on the time point that it occurs and also state exactly when you're looking or if you're recording any events that potentially happen throughout a patient's cancer treatment. That being said, we also have to do better for comorbidities. When we look at risk assessment models and developing personalized approaches to VTE prevention within these populations, we really have to see, okay, who is at the highest risk? We have to look holistically at the patient. And if we don't have that holistic view of the patient, it's going to be very, very difficult to develop those perfect models. Lastly, I would like to see representation from more countries in the world because as soon as we kind of move towards developing models, even developing something as a prophylactic guideline, there are a lot of individuals who are currently not represented based off the data that is available. And therefore, we really have to try and fill in those gaps to determine the best optimum approach to patient care.
I couldn't agree more, Jordan. And it just pops to my mind now, the common data elements for standardized research in VTE that was taken by the ISTH committee led by Dr. Gregoire Lagal in Ottawa. And this actually CDE library is available online to guide researchers to use terminologies when they come to do research, conduct research, and report research with respect to cancer-associated thrombosis or VTE. And I think if people across the globe follow this guidance or this library, I think we will have much better studies, and that will help compilation and also meta-analysis of these studies. So I hope people can look at this, and maybe we can put a link to this library under the podcast if David is okay with that.
Yeah, that would be amazing.
Okay. Can you tell us a bit about the risk of bias in the included studies?
Yeah, so we assessed the risk of bias across 6 different domains, and we actually generated a very detailed description of each of the categories and how we would sort into categories. So we were very sure prior to starting exactly what we were doing to limit our bias as authors. So we were stringent and we erred on the side of caution. So if anything was unclear whatsoever, we were very open and honest about reporting that. So we determined that if any singular domain was high risk, we actually rated the whole study as high risk. And then if we couldn't find the information and more than 50% of the domains were unclear, we listed as unclear. So the breakdown was as follows. Out of the 124 studies, 45 were categorized as high risk, 47 as low risk, and 32 were as unclear. When we looked at those 45, we really wanted to see, okay, where is this high risk coming from? We found that 40 of these studies were classified as high risk due to generalizability. So overall, the findings were very small populations within a singular hospital setting, within a singular country, and could not be applied to a broader data set. Looking at it from the global perspective, where we actually broke each thing down by country, this was not overly concerning to me as an author because we were able to kind of give a complete picture for a country. I like to think of how we would use this data set as, say you were from Japan and you were doing a study specifically in Japan, and you wanted to look at the incidence rates within Japan itself for different types of cancer. We have broken that data down so you can look exclusively at that population. So you can either look at the generalized data or the individual data. So we hope to mitigate some of that risk that way. The other way that we really wanted to report it is we included a figure where we looked at each individual type of cancer and we provided the overall risk breakdown for each type of cancer. So the thought process is if you're only interested in lung cancer, for example, you could go to this figure and you could assess, okay, how much do I really trust the outcomes of these results? We also provided a breakdown by domain so you could explore it further if you were concerned about one of the studies in the high risk category. So overall, we did our best to ensure that everything was very transparent and people could use this data set to the maximum of its ability.
Great.
Right. So I guess now that we're coming close to the end, what are the implications of those findings, and how do you think we could use this data moving forward?
Overall, we observed that there was differences in the incidence of VTE between different types of cancer, sex, and the global perspective, as well as identified areas where we need to have more information. So all in all, I think this data can be used to help identify high-risk patients and also work towards developing and optimizing risk assessment models. So by having all of this data in one singular place, clinicians and researchers can access this summary versus having to independently find every study that they can on their topic. We hope that this will help target research and clinical interventions to the high-risk areas and help make a tangible difference in terms of cancer-associated thrombosis, incidence, morbidity, and mortality. Additionally, we hope that that narration on all the different limitations that we had would really help move towards what you were discussing for that standardized reporting and really showing how having a data set that is fully accessible to different questions can really make a difference in terms of expanding the world of research.
Wonderful. Thank you.
Okay. So is there anything else that we didn't talk about today that you'd like to add? Any specific recommendations that you found from the study?
Something that I found that was really important that I would like to add is given my experience between research, nursing fields, as well as being a person who's had a lot of different family members experience cancer, but unfortunately, none of us have actually really received a lot of information about VTE and cancer. So first and foremost, I'd like people to look at this data set and see that there is a high incidence of VTE in cancer and really help that emphasize its importance of integrating it into oncology care and ensuring there's increased attentiveness to monitoring VTE in patients. One thing I'd love to share is since disseminating the results of this study at multiple different conferences, I've had the ability to talk to a lot of individuals, especially from the patient's perspective. I actually, at the first conference I shared this at, had a patient come up to me and say, "Thank you so much for discussing this. No one had ever mentioned it to me before. And my experience with VTE during my cancer was actually a lot worse than my cancer treatment, the chemotherapy, and all the side effects. And I really wish that I had known and could have prevented it or worked towards identifying it before it got so advanced. So I really wanted to take that point and allow it to hit home that it's important when we're doing research to always consider that patient perspective and always think about how our outcomes can really translate to improving care for our patients that we serve.
Wonderful. Thank you so much, Jordan, for sharing your paper, your insights, and experience with the data collection and analysis.
Thank you, Jordan. It's great to have you on, and thanks for the insights from your paper. And I'm just going to put a plug in here for Thrombosis Canada because we have a whole collection of cancer-associated thrombosis materials and resources, both for healthcare professionals and patients. We just recently added the Corana Risk Score calculator onto our app, so all of those things should help in some way in informing patients and ensuring that families have the information they need to help their loved ones through the cancer journey, and particularly if there's some thrombosis involved. To read the full publication, we will provide a link to the publication in the notes for this episode, as well as a link to some of the cancer-associated thrombosis resources that we have on our website. I want to thank our audience for joining us on Clot Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. And you want to stay up to date on the latest in thrombosis, hit that subscribe button so you never miss an episode of Clot Conversations. We've had a lot of interesting episodes lately, especially from ISTH recently. So take a look at what already is on our podcast and enjoy listening to those. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference coming up this fall. Your support matters. Consider donating to Thrombosis Canada to help us continue the fight against thrombosis. Thank you, everybody.